Okay, good evening, everyone. So welcome to the 2024 Helen Glass Research Symposium. This is the first in-person event that we've had since 2019, and we have a really great evening planned for everybody. I would like to begin by thanking some of the key people who are responsible for this event. I would like to thank the event staff at the Canadian Human Rights Museum, and this includes the AV team, food and beverage staff, security, and Atiza Toledano, the event coordinator. I would also like to extend a special thank you to the College of Nursing faculty and staff volunteers who helped with setting up the event for this evening. And most importantly, to the 2024 Helen Glass Research Symposium Planning Committee. I would like to take some time to extend a special thank you to Sandra Ericasia Summers and Alan McKenzie for all of their hard work. So before we begin our event, if I could ask Sandra and Alan if they could step forward, and we just have a small gift for them. And I just realized that I have not introduced myself. So my name is Nicole Harder. I am the Associate Dean of the Undergraduate Programs at the College of Nursing. I am the MC for this evening. Dr. Marnie Kramer was to MC the event. She's the chair for the planning committee. However, her flight from Saskatoon did not make it in. So I am assuming her duties on her behalf. So as we begin, I would like to introduce Dr. Neither Dick, our Dean of the College of Nursing, to provide a land acknowledgement and some opening remarks.
Thank you, Nicole. And good evening, everyone. As Dean of the College of Nursing at the University of Manitoba, I am delighted to welcome you to the 2024 Helen Glass Research Symposium. Thank you for coming, and we look forward to your participation. I would like to begin by acknowledging that the Canadian Museum for Human Rights is located on Indigenous ancestral lands on Treaty 1 territory. The Red River Valley is also the birthplace of the Métis. We acknowledge that the water in the museum comes from Shoal Lake and are grateful to the First Nations that care for that water. The University of Manitoba campuses are located on original lands of Anishinaabe, Cree, Ojibwe-Cree, Dakota, and Dene peoples, and on the homeland of the Red River Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. And we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Hosting the Helen Glass Research Symposium is a singular highlight for the College of Nursing each year. The Helen Glass Research Symposium is a time when we showcase the stellar research within the College of Nursing and invite a renowned researcher in residence to help explore a pressing issue within the context of where nurses work. Tonight, we explore Canada's health workforce crisis and how research can guide solutions. The stress of the COVID-19 pandemic amplified pre-existing challenges in the healthcare system, leading to widespread staffing shortages, as well as exhaustion and burnout among healthcare professionals. The House of Commons Standing Committee on Health conducted a study on Canada's health workforce to determine how the crisis can be addressed. The committee received testimony from national and regional health authorities, from professional organizations, educational institutions, from nonprofit organizations, and individual healthcare professionals and other healthcare stakeholders. And the lack of supply of health professionals and mental health issues among health professionals emerged as the central issues. So we're pleased to welcome Dr. Lynn Bourgeault as our 2024 researcher in residence to explore these critical issues in more detail and to highlight the urgency and importance of research in addressing the health workforce crisis. This evening, we invite you to view the donor board displaying our remarkable researchers in the College of Nursing. We're so proud of our researchers and their engagement in research that is highly impactful. In this past year alone, they were successful in securing grant funding amounting to $2.4 million and disseminating new knowledge through 87 publications and 101 presentations. We would also like to recognize our impressive team of researchers and graduate students whose research is focused on the health workforce crisis. And most importantly, we would like to thank our nurse leaders for their excellent leadership and our practicing nurses for their dedication to quality patient care and to keeping the system operational, no matter what the challenges. Thank you for everything that you do to support the health of Manitobans. Our hope is that research can serve to further enhance future practice environments. Finally, we'd like to thank the Dr. Helen Glass family, Susan Glass and Arnie Thorstensen, for their generous support of this symposium. Dr. Helen Glass was a dedicated pioneer of the nursing profession, an esteemed leader, colleague, and friend. She was adamant about bringing champions in the area of nursing research to the College of Nursing to share new perspectives and stimulate the generation of new ideas with nursing students, faculty, staff, and the public. We take great pleasure in honoring Dr. Helen Glass and sustaining her legacy in nursing research and education. I'm very pleased to introduce Dr. Vanessa Van Buur, our assistant professor in the College of Nursing, and a Red River Métis scholar and storyteller, to provide us with a welcome for this evening.
Merci, Nitha. Bienvenue, mes amis. Welcome this evening to this event on Treaty 1 territory and on the homeland of the Red River Métis. When people think about Indigenous lands, they often think about lands far away, remote, out there. There are common misconceptions that urban Indigenous people are not as culturally and spiritually connected to the land upon which they live. If I tell someone I grew up Métis, never denying my dad's English settler ancestry, I'm often met with, from where? If I answer Winnipeg, it is often met with, but where are your Indigenous ancestors from? Not recognizing that Indigenous people lived all over Turtle Island, including on lands that are now cities. And also not understanding that in Métis communities, the question is not so much where are you from, but rather who are you from? On my mother's side, I'm from the Beauchemins, the Poitras, the Delormes, and the Ducharmes. The place we have gathered here tonight holds particular significance for Indigenous peoples. The Forks was a historic gathering place and trading center for the Innu, the Anishinaabe, and Dakota nations prior to European contact. It is also the heart of the Métis Nation. We came to be a people here at the confluence of the Red and the Assiniboine. The Red River's resistance began here at Upper Fort Garry, led by Louis Riel, as the Métis fought against the transfer of their lands to the Canadian government. This resistance resulted in the negotiation of the Manitoba Act, which established Manitoba as a province with linguistic and religious protections and provisions for Métis and First Nations peoples, both acknowledged as Indigenous and having rights to land in the Act. The government negotiated land claims with First Nations groups as a collective, and this resulted in the numbered treaties. However, the government did not want to enter into this agreement with the Métis. One, they'd begun to realize how costly these treaties were going to be, and two, they'd had enough experiences and conflicts with the Métis to know they did not want to negotiate with them as a collective. So the government devised a system where the Métis would be offered scrip, essentially a coupon that they could redeem for land or a coupon that they could redeem for money to buy land. But the system was rigged right from the start, and the loss of Métis lands was all but a foregone conclusion. Right off the bat, the government delayed the delivery of the scrip system for years. They only moved forward under threat of conflict by the Métis. This resulted in many Métis becoming disillusioned and distrustful of the government's promises, and they headed west or to the US before even receiving their allotment. When finally implemented, the process of applying for land scrip was arduous and complex, burdened with numerous government restrictions and bureaucratic hurdles. It involved filling out no less than 9 forms, navigating Canada's financial and legal systems, tasks near impossible for many Métis. To add insult to injury, many Métis were given land far from home. If they accepted the land they were given, they had to uproot their lives, leaving behind much of their tight-knit family to begin a new life in an area they did not know, on lands they had never seen, often traveling days to do so. The government also alerted land speculators by advertising the location of scrip applications in English newspapers and on posters. Many Métis, unable to read or write, unknowingly sold their scrip to speculators who accosted them outside of these locations. Unsurprisingly, the value of scrip that they were offered was much less, leaving Métis further impoverished and disconnected from the land. The scrip system also lacked protection against fraud, allowing impersonators to claim scrip meant for the Métis. Government officials were also known to mishandle scrip and disregard land claims, worsening the situation. Now, even if an individual did manage to negotiate all that complex terrain, the onerous requirements of land ownership, including mandatory improvements to the land within 3 years, high taxes, and occupancy requirements that precluded leaving for the buffalo hunt, often resulted in the Métis being evicted from their lands. This is the case for many of my ancestors who were given and then evicted from land in what is now present-day Norwood and St. Vital, right here in Winnipeg. When I was a teenager, I walked from my high school, Collège Louis Riel, in St. Boniface, across the Red River to the Forks several times a week to attend dance classes here. With no smartphone to occupy my time, I spent so many of those walks in reflection, pondering the grounds I was walking upon and the river I was traversing. As I crossed the Provencher Bridge, a bridge my grandfather helped build, I would reflect on the mystery of the Red River. Water is life, but it can also be death. I wondered how many secrets, tears, and losses the Red River had consumed. How many young women were brutalized and discarded in this river? How many curious children had fallen through ice still too thin? And why would men who had once built bridges jump from them? In those days, despite attending a school named after him, our history textbooks, written in French and sent from Quebec, only peripherally included the story of Louis Riel, the Métis, and their collective importance to the building of Canada. The English textbooks were even worse. The Métis were portrayed as uneducated savages, and Louis Riel as a traitor. Fortunately, we had teachers who taught us our story as Métis people off the page. Despite limited validation and representation, and unlike the generations of our parents and grandparents, we were proud of who we were. At school rallies and during team sporting events at Collège Louis Riel, we had a chant. Louis, 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 Collège Louis Riel. Louis, 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 Collège Louis Riel. Louis, Riel, Louis, Riel. Louis, 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 Collège Louis Riel. A student body, Métis and Francophone, chanting their Francophone Métis leader's name. But there were gaps in our teachers' knowledge. We did not know that the school had formerly been a boys' juniorate, relocated from half a block away after a fire burned down that building, killing a priest and 9 boys. Nor did we know that prior to being a juniorate, that building had been the St. Boniface Industrial School, a residential school funded by the Canadian government and run by the Archdiocese of St. Boniface and the Grey Nuns of Manitoba. From 1890 to 1905, approximately 300 children, half Métis, half First Nations, attended the St. Boniface Industrial School. 87 of them died during or shortly after their time at the school. Most of these children were buried in unmarked graves in the St. Boniface Cathedral Cemetery, which is also the final resting place of Louis Riel. This past February, I walked into Collège Louis Riel to watch my oldest son's basketball game. The school is virtually unchanged structurally, but the entrance and hallways were replete with photos, posters, and literature on Black luminaries and Black excellence in honor of Black History Month. This is something we had not celebrated at Collège Louis Riel when I was young. I then walked into the gym and saw my firstborn gathered in a huddle with his teammates and coach. Unlike in my time, he was the only Métis person on the team. Every other person, including his coach, was from the African continent. They ended their huddle with the same refrain we had chanted years ago. Louis, 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 Collège Louis Riel. Louis, 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 Collège Louis Riel. Louis, Riel, Louis, Riel. Louis, 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 Collège Louis Riel. This was a vision beyond Louis Riel's wildest dreams. That people who came from lands as far away as Ethiopia, Cameroon, Mali, Senegal, Djibouti, Tunisia, among many other countries, would know who he was and would be chanting his name. But it seemed fitting. After all, Louis Riel did not just advocate for Métis rights, but for the rights to religious and linguistic freedoms for all in Manitoba. I'd like to end this story with a spoken word I wrote. It's written through the voice of Louis Riel from the time of his hanging in 1885 to present day. It's called Manitoba, or The Narrows the Great Spirit Built. I'll rest my eyes this eve for a century of moonless nights. I'll start over. I'll rest my eyes this eve for a century of moonless nights. My children will live in the margins of every book you write, denied of their own story and of your promise to their rights, ashamed of who they are, abandoning the fight. But one dawn I will awaken to the tremble of 10,000 feet. The sound of laughter and singing will echo as you creep. The red is rising, you will decry, afraid of what this means. We were never born by fourths or halves. We never called ourselves half-breeds. Well, the war was never won by cannon, rifle, or rope hung. The war is won through prose and paint, our artists just begun. Surely you can see me now, in shadows I'll live no more. I'll take my place by the sun as my people take the floor. Whether by scrip or by treaty, by treason or wooden yoke, we are the face of a province, both the ember and the smoke. We are the jingle, we are the jig, we are the hoop, we are the round, we are the narrows the Great Spirit built. We were never lost and never found. Merci.
Thank you so much, Vanessa, for those very powerful words, and what a wonderful place to have these spoken. Just a message from Marnie Kramer. She has a small gift that she wanted to bring to you, and she has a photo there. And it is a rug hood picture by Shelley Nicole Phillips, a Regina artist who's inspired by the vast prairie landscape. So I'm supposed to tell you it's coming to your house this week. So thank you very much, Vanessa. Thank you again. Next, I would like to invite Dr. Diana McMillan, Associate Professor and Clinical Chair at Health Sciences Center, to provide a tribute to Dr. Helen Glass.
Thank you, Dr. Harder, Dr. Bourgeault, Dr. Dick, honored guests, faculty, students, and friends. Bijou, bonsoir, and welcome. My name is Dr. Diana McMillan, and it is my great pleasure to offer a tribute to Dr. Helen Preston Glass, who I knew personally as a nursing pioneer and visionary, a mentor and a friend. It is really hard to capture in the span of a few minutes the impact that Dr. Glass has had on the profession of nursing, the Canadian healthcare system, its policy, the College of Nursing, and me personally, but I will try to offer some highlights. So, to start, Dr. Glass was born in Regina, and in 1939 earned her diploma in nursing and her nursing registration from the Royal Victoria Hospital School of Nursing in Montreal. She moved to Winnipeg as a single mother, and here earned a certificate in teaching and supervision from the University of Manitoba, later teaching at the Victoria Hospital School of Nursing. Now, like many nursing leaders of her era, she went on to graduate from Columbia University, earning her Bachelor of Science and Master of Arts degrees, and later returning to Columbia for a master's and a doctorate in nursing education. From 1972 to 1979, Dr. Glass was the director of the University of Manitoba School of Nursing and a visionary leader supporting nursing and research. During her leadership, she was pivotal in the establishment of our graduate nursing program and the Manitoba Nursing Research Institute. She was familiar with the national and international stage, contributing her leadership as president of the Canadian Nurses Association and having a major influence on the wording and scope of the Canada Health Act. She worked tirelessly, driving healthcare policy, nursing education, nursing research, both nationally and internationally. She has many, many honors and distinctions, and these include the Queen's Silver Jubilee Medal, the YWCA Woman of the Year Award for Education, Member of the Order of the Buffalo Hunt, and the Officer of the Order of Canada. Well, it was from 1990 to 1993 that I had the very good fortune to serve as Dr. Glass's research assistant. I was a Master of Nursing student at the time, and Winnipeg was preparing its bid to host its second Pan Am Games. Dr. Glass saw a need and an opportunity to build a world-class residence for the athletes and leverage a much-needed and world-class new nursing building. I was hired to assist with this project. Well, nothing was impossible when this dynamo brought her vision, astute timing, hard work, and evidence-based persuasion to the table. And she was bold and well-connected. The first time Dr. Glass asked me to get Gary or Michael on the phone, I am sure I gave her a very quizzical look. But I soon learned to dial Premier Gary Filmon's office and author Michael Rackless's number with practiced expediency. She had an ability to gather the right people around the table, to think 3, if not 5 steps ahead, to see win-win possibilities, and to be fearless. Not surprisingly, her vision took hold, and 89 Curry Place, our new and current nursing home, was built. In 1999, the Helen Glass Center for Nursing on the Fort Garry campus was dedicated in her honor, and I even had the pleasure of piping her into the building. What a great day. And with typical Dr. Glass flair, Her Royal Highness, the Princess Royale, was present during the Pan Am Games that July to open the Princess Royal Walk. And for those of you who may not know, it is that lovely bricked path joining nursing and education named in the Princess's royal honor. Helen was indeed a wonderful mentor to me, always supportive, encouraging, and kind, explaining her thinking and actions in a way that reflected her deep love for teaching and her incredible capacity to inspire the possible. And to be sure, my 4 young daughters adored her little dog that she carried in her purse. However, one of the most important and lasting things that I have learned from Dr. Glass was to lean into the discomfort. For Dr. Glass, it was imperative that nursing share their voice and their expertise, and that despite any anxieties that we may have, we still need to step up, be seen, and be active at the table. Every time the media calls me to do a sleep interview, I think of Dr. Glass and smile and lean in, making time to share my nursing voice. And I have regularly shared Dr. Glass's encouraging words with my students and colleagues. The Helen Glass Symposium at the site of the Manitoba Human Rights Museum is a fitting reflection of this wonderful and inspiring nursing leader. It is an event that showcases renowned speakers such as Dr. Bourgeault that challenge our thinking and encourage us all to be leaders and champions for healthcare. Dr. Glass would be so delighted. Thank you.
Thank you so much, Diana. Next, I would like to invite Dr. Linda Bourgeault, Professor and Associate Dean Research, to introduce this year's Researcher in Residence.
Good evening, everyone. It's lovely to see everyone was able to make it out tonight. And it's my real honor to be introducing Dr. Ivy Bourgeault. We shared earlier today a discomfort with long introductions, so we're going to keep it sweet and short so we can have lots of time to learn from Ivy today. So we're so honored to be welcoming you, Dr. Bourgeault, as this year's Researcher in Residence. For those that haven't had a chance to look at the brochure, Dr. Bourgeault is a professor in the School of Sociological and Anthropological Studies at the University of Ottawa, and there she holds the University Research Chair in Gender, Diversity, and the Professions. She is nationally known for her work in health workforce. She leads the Canadian Health Workforce Network, the Empowering Women Leaders in Health Initiative, and she co-leads the Team Primary Care Training for Transformation project. And I think this theme of transformation is one that we're going to hear a lot over the next 2 days. For this work, she was honored with an induction into the Canadian Academy of Health Sciences in September 2016. And that year, she also received the University of Ottawa's Award of Excellence in Research. Dr. Bourgeault is known internationally and holds an international reputation for her research on the health workforce, particularly using a gendered lens. Her previous research projects has examined such topics as migration and integration of health workers, and on primary and maternity care workforce issues. More recent projects have focused on care relationships in home and long-term care, and on the psychological health and safety of professional workers. She's been sought out as a consultant by various provincial ministries across Canada, as well as by Health Canada and the WHO. She has numerous board experiences, among them serving on the CIHR Institute of Health Services and Policy Research. We're very fortunate to have Dr. Bourgeault joining us tonight. I know that she has lots to share, and I hope you'll engage her in dialogue over the next 2 days. Welcome, Dr. Bourgeault.
Thank you, everyone, for coming out on a chilly evening. I'm very, very, very pleased. I'm just going to get myself ready here with all of my accoutrements. And this is sort of the state that I'm in. I have 2 different sets of glasses to see various and sundry things. Sorry, I'm just going to get my things set up here. So first of all, I want to say how honored I am to have been chosen to be the researcher in residence for the Helen Glass lectureship. It is an absolute honor, and I really appreciated some discussion of her background. And just to kind of build on the leaning into the discomfort, there's going to be a lot of that. So just buckle up. I also want to say how moved I was with the story. So thank you so much for sharing the story of having a background in being Métis, this particular territory. So I'm very honored and moved by that. I take time to affirm my commitment to implement the calls to action of the Truth and Reconciliation Commission. And so it really goes beyond acknowledging territory, but I want to be respectful of where we are. I want to extend my respect for maintaining a knowledge and spirit despite all of these colonial incursions that are not only historic, they continue to this day. And it has been uncomfortable witnessing some of those, seeing them, and then trying to do the work of being a good ally as a settler. When I hear my biography, I identify as this very awkward child that grew up in Marceline, Saskatchewan, halfway between Prince Albert and Saskatoon, very much in Treaty 6 territory. I grew up with the privilege of learning Cree as well as French in school. I thought everybody did, and so that was really unusual when I realized that that was not the case. And so I often honor Mrs. Arcand, who brought that to our school. And then, just to acknowledge this being integrated into the work that I do. So what I must remember is that when I change slides in front of me, that I also change slides for you. So if I start running off, ahead with the slides, please raise your hand and say, please pass the slides on. So I want to raise an issue with you, an issue of our times, an issue that is really part of the social fabric that is being Canadian, and that is our healthcare system. And that we have this, in part, sense of moral superiority to our neighbors to the south, that we all have access. And that access has been on the back of health workers. And, I'm going to evoke my farming background here. The chickens have come to roost. So this is a very, very important issue. As a researcher, I do feel strongly that research can help us address this particular knot that we are in. So it was mentioned in my biography that I lead the Canadian Health Workforce Network, and I have led the Canadian Health Workforce Network for over 12 years. I think it's 13 years now. And what we do, you can all become members of the Canadian Health Workforce Network. It's free. We are really about building capacity. And we have a number of different researchers, both embedded researchers within the system as well as within academia, to apply their internationally recognized expertise, building partnerships with community to bring innovative solutions to the complex health workforce challenges. And these are just a number of the theme groups that we have leads for, and the focus on some particular sectors of interest. So I just wanted to make sure that you knew who we were. What I think is really important with a talk is to kind of give it to you in one slide. So if you have to leave early, this is it. And so want to highlight and going to sort of walk through the problem space. But I think you're all quite familiar with the problem space, so I'm not going to spend too much time on that. But basically to say that we are caught in a vicious cycle that involves heavy, heavy workloads, which lead to burnout, which leads to attrition. And I'll talk a bit about what attrition looks like. And this has critical population health impacts. The WHO says, there's no health without a health workforce, and that is very important to identify. I wouldn't be doing my job as a university research chair in gender diversity and the health workforce if I didn't make it very clear that gender impacts this vicious cycle. and it needs to be explicitly considered both in a set of reactive and proactive solutions. And an integrated set of solutions should include embedded evaluation to inform policy course correction and to build capacity in the type of research. And Canada has critical untapped resources that really ought to be leveraged to spread and scale innovative solutions. That untapped resource are the folks who have been doing health workforce research and the students who are starting to become health workforce researchers. That's very important. So if you can only stay for a few minutes, this is the presentation in one slide. All right, so we're first going to talk about the problem space, and like all icebergs, the problem often lies mostly below the surface, and so I want to kind of shine the light on that part. So this is a visual that I use to really strengthen about this vicious cycle, that we have work overload, burnout, and rising attrition. This vicious cycle existed prior to the pandemic. The pandemic accelerated it. So we have work overload, which leads to burnout, which leads to rising attrition. And attrition can be expressed in a variety of different ways. It's not just workers leaving their position, although it definitely includes that. It could mean them changing their position to another place that maybe doesn't have as high acuity. It could also mean they're moving from a full-time to a part-time position. And if we are only keeping track of data on headcounts, we are missing that entirely. This cycle of work overload, burnout, and attrition is gendered, and it needs to be interrupted. We absolutely have to interrupt this vicious cycle with a set of reactive and proactive solutions. This hasn't been invisible to the public. We were really pleased because we're a pretty lean organization, and by lean I mean we're a volunteer organization. So we were really happy when the Angus Reid organization reached out to us and asked us if we would like them to include a question on the survey. And I said, one question is nice, how about 3? And they agreed. And they created this question that had sort of 3 components. So the first was, are you concerned about the mental health of healthcare workers? And if so, are you concerned of what this means about your access to care and the quality of care? So those were the 3 sets of questions. And these are the results. 9 out of 10 Canadians were concerned about the mental health, and 8 out of 10 about what that meant for their access and quality of care. Now, this was done in 2022, and this has just gotten worse. And so I would imagine that the Canadian public would be even more concerned. So let's try to unpack a little bit of this from a gender perspective and to talk a little bit about how health work is gendered. It is gendered in an incredibly pervasive way, and yet we often don't shine the light on it because it is so pervasive. The bulk of the health workforce in Canada, as it is globally, are those who identify as women. In Canada, it is actually greater than the international average. Internationally, it's about 70% of the workforce, and in Canada, it's over 85%. And those are the workforces that we count, so keep that in mind. That doesn't include all of the personal care workers and the 20 different labels that they're referred to. So it's important to also think about not just the gender of who is doing that work, but the gender of the work. So healthcare work is what we describe as structured along gendered lines, and it is permeated with not just gender identity, but gender roles and gender relations. If you don't think healthcare work is gendered, then statistics like nurses experience more violence than police officers, statistically. That's just something to kind of underscore the importance of this and the invisibility of that issue. So gender shapes both the structural location of men and women in the health workforce, both within and between professions, As was noted in my bio, I've been part of this Empowering Women Leaders initiative, and that's been very interesting to think about the gender leadership pyramid that there is. The WHO describes it as women deliver care, men lead. Gender also shapes the classification of work as being skilled or unskilled, assuming that you don't gain skill through experience, but only through, university-identified credentials. And so that's very important. So to say that, for example, personal care providers are unskilled is really to not recognize the work. And just as a very quick aside, my husband is the main caregiver for his mom and manages a variety of different personal support workers. And so he's figuring this out because he said, the men, they don't do as much as the women when they come over. And so I think when you, I'm going, yes. And not to be binary about this, and not to say that, men can't be caring or can't learn to be caring, but there is this notion of the socialization from day one that girls and women have. And I think again, leaning into the discomfort a little, I would be remiss to say that there is a broader societal undervaluing of the work that women do, both formally and informally. And that needs to be acknowledged. So I don't say these things just in a theoretical, sociological way. Sociologists like to problematize things. But if we don't, acknowledge this, we are not going to develop solutions that are going to address our problem. So I'm going to walk through a few sets of slides just to try to kind of understand or underscore this. So the health workforce in Canada is increasing in size, especially for women. So the red line is the increase in the labor force in general. The green line are men in the health workforce, and the yellow line are women in the health workforce. So the health workforce is predominantly delivered by women, and it's growing. But this so-called feminization, more women going into the health workforce, is not evenly distributed. So the one graph on this side gives you the proportion of women in certain professions. The dark line is in 1987, and the pink line is in 2016. So these are data that were analyzed by a colleague who used to be at Chi-Hi. She's no longer there anymore, and it's actually quite difficult to pull these data out of the publicly available data from Chi-Hi. So you can see that dentists have a low proportion of women, but that's increasing, so from 20 to 33%. And if we look up at licensed practical nurses and registered nurses, it's at, initially in 1987, 95, and it's reducing down to 89%. Registered nurses and psychiatric nurses going from 93 to 90%. So these are the only professions where the proportion of women in the profession is going down. So it's helpful that you're getting more men or more nurses who identify as men in the profession. So it's important to note, again, getting back to that initial slide, that there's a gender division of labor within healthcare. The infographic of men and women in the different professions are more recent data from 2022, where over 99% of midwives identify as women. And in fact, it's often because we don't offer a non-binary option, because that would be a lower proportion in the case of midwifery. So, but 99% of midwives, dental assistants, dental hygienists, dietitians, genetic counselors. So nursing is not even in the top 5 of the most gendered female professions. And on the alternate side, these are the professions, regulated professions, where men predominate. So 67% of medical physicists, like 64% of paramedics, 63% of chiropractors, and 56% of physicians identify as men. Gender also has implications for service capacity, but so does age. So this is when we start talking about the need for an intersectional perspective. And we can only do this intersectionally because we capture so poor data in terms of Indigenous identity or ethnicity. But the slides there just are a snapshot of the average workload by specialty and gender for physicians in 2015. So the yellow bar is women, and the green bar is men. So you would look at that and say, well, the increasing proportion of women in the profession of medicine, maybe that's what's causing our concerns about the lack of capacity. So just hold on to that thought. The other slide is very recent data, which captures income tax data. This is a team led by my colleague Arthur Sweetman at McMaster Universities that looks at weekly average hours worked by physicians in Canada, adjusting for sex or gender and age and sex from 1987 to 2020. So this is prior to the pandemic. And you can see how it is going down. Service capacity is going down. Service capacity is going down, accounting for gender and accounting for age. So it's not just, as is simply put in the first diagram, about women in medicine. There is an overall capacity. So part of the explanation could be unpaid care work at home. And this is what the OECD has talked about as the missing link in the analysis of gender gaps in labor outcomes. In general, this is not specific to the health workforce. So there are key messages here. Around the world, women spend 2 to 10 times more on unpaid care work than men. So that's not just health care workers, but that's in general. This unequal distribution of caring responsibilities is linked to discriminatory social institutions and stereotypes on gender roles. And gender inequality in unpaid care work is the missing link in the analysis of gender gaps and labor outcomes such as labor force participation, wages, and job quality. So if you're concerned about attrition and you're not taking gender into consideration and therefore unpaid care work, you're missing a lot of that. And as the last bullet point notes, this is really about socialized gender roles. So gender matters. Now, what data do we have in Canada that might speak to this? I'm very sad to say that the most recent data for Canada for physicians is a tiny question over 20 years ago in the 2002 CMA survey of physicians. And they looked at physicians with children under 18. So it was a survey of all physicians, and then they did a subset analysis of physicians with children under 18. And they were asked to guesstimate how much unpaid care work that they did. The men guesstimated that they did 15 hours, and the women did 42 hours. So if you take this information and you go back one slide to interpret why men have more paid hours than women for medicine, you can see that there are profound differences that have important implications for capacity. Now let's look at what happens with nursing, and my apologies, that's a little small. This is a really interesting scoping review recently done where they looked across 20 different studies on this phenomena called double duty caregiving. And what that means is that you are caregivers at work and you are caregivers at home. And what happens in that regard? So this is particularly the case for health occupations where women predominate, but also social work, childcare, etc. That double-duty caregiving causes mental and physical pressure to the caregiver, developing symptoms of overload. Remember the cycle? It's gendered. Double-duty caregivers need flexibility. Social support from the workplace is not enough. Organizations often wait too long to act instead of taking more preventative measures. We lose workers, health workers in the system. We waste them. And when they're gone, we do very little to get them back. This was a very interesting study. This is 2011 data from the Netherlands. As healthcare workers provide more hours of informal care in their private lives, their mental and physical health significantly worsens, while their need for recovery increases. There's statistically significant increases for emotional exhaustion and presenteeism, being at work when you really ought not to be, and negative experiences with work-home and homework interferences. So here's our conundrum. The health workforce in Canada is increasing in size, especially for women, but healthcare work capacity overall is decreasing. And if there's one take-home message from this lecture that I want you to go away with, is that head counts does not equal capacity. So the next time you hear someone talk about the provider-to-population ratio and how we have many more registered physicians or midwives or nurses than we ever had before, counter with this. Head counts is not equal to capacity. This is our little diagram that says you have to take the workers and talk about the inflows and outflows and who's participating in care, what's their activity, what's their productivity rate. There's a very big difference between head count and service capacity. And we also need to keep in mind that the population health needs are growing because of aging. We haven't been modeling long COVID. Well, we've started to do so in Toronto, and burnout. So population health needs are growing because of aging, demographics, and chronic conditions. All right, you knew about the problems. I just kind of highlighted that for you. Let's talk about the solutions, because that's what I'm here for. So in a report that we were commissioned to do by the Canadian Federation of Nurses Unions, but these solutions apply across professions. We need to move from our vicious cycle to a virtuous cycle, the triple R. Retain, return, recruit. We have everybody not saying recruit and retain. Retain, return, recruit. You have to start with retention. And then you have to have this triple E cycle, which unfortunately doesn't translate into French as well. We need to embed planning. We need to enable access to data and enhance data. And gender needs to be taken into consideration across these. So let's talk first about our triple R cycle. Let's start work with retention. Why? Because that's the best return on public investment, is to retain the workers that you have in the system. A colleague in the United States at one of the Centers for Health Workforce Studies had a health economist do a calculation of, for every dollar you spend in retention, it costs you 10 in recruitment. So if you have limited public funds, retain your workforce. So here are some of the items that we had, and this is both derived from the Sustaining Nursing in Canada report and the Canadian Academy of Health Sciences report that came out in 2023. So rebalance and redistribute workloads. Workloads really do matter. Increase optimization of the scopes of practice collaboratively through integrative models of care. And I have the little sign for our Team Primary Care initiative there because that's what we were hoping to do. We need to have an all-hands-on-deck approach. There are health workers that we need to bring into the public system to improve the circumstances. We need to improve and harmonize wages and benefits across different settings and practitioners. We need to implement initiatives targeted across the life course, because gender matters, but so does age. What works for late career nurses does not work for early career nurses. Sometimes you can put those two things together and it can work. You need to foster safer, more supportive and equitable work environments, and you absolutely have to address the violence. There was a 2010 House of Commons Standing Committee report that talked about it, and one of, I think, the 40 recommendations have been implemented, and that's only because workers were being harassed during COVID. So there's work that needs to be done there. The missing piece, return. We need to return workers. We need to return them to the public system. You know, that folks who have gone to agencies, private agencies, an insidious form of privatization. I can talk about that for a long time. We talked about initiating a public agency of mobile health workers in the Canadian Academy of Health Sciences report. Find out how to return recent leavers and early retirees in different roles, such as mentorship roles, and return to practice those who are here with international training. So integrating internationally educated is part of the return. We need to recruit and mentor strategically. You need to expand domestic programs by increasing seats, particularly to address underrepresentation, and I understand there's some really important initiatives here in Manitoba to address Indigenous participation in the health workforce. And you do so by forming partnerships with different Indigenous, Black, and other organizations, including, and we do a lot of work with Société Santé en Français to make sure that folks who speak French outside of Quebec also have access to services. You need to increase the faculty complement if you're going to be increasing domestic training, and there should be diversity as well in the faculty. You can't, it's more difficult to be what you can't see. And then support trainees to work in underserved communities and sectors such as long-term care, and implement other promising solutions like student loan forgiveness across the different practitioner groups. And why don't we offer free tuition, government-supported free tuition, publicly supported free tuition? They have done that in the UK. And in fact, when they were trying to remove that, there were huge protests. And so the reason why we start with retention and end with recruitment is we need to be reminded that we have signed on to the Global Code of Practice on the International Recruitment of Health Personnel. We signed on to this in 2010. It is going to be renewed this year, reviewed, and we are undertaking a review in that. I highlight some of the key principles here, that ethical international recruitment is discouraging active recruitment from developing countries facing critical shortage. And guess what? All countries are facing critical shortages. The shortages that we are experiencing are eclipsed by the shortages that are experienced elsewhere. The code also says that there should be international cooperation between source and destination countries for there to be mutuality of benefits. So there needs to be technical assistance and financial support, but we have really not done that. We're doing better at migrant health personnel receiving fair and equal treatment, but again, here is a huge number of resources that we're wasting. And here's something that we're only just recently paying some tepid attention to. Countries are encouraged to strengthen health workforce data gathering and implement effective health workforce planning, development, and sustainability strategies. So I'm just going to highlight one of the things. When we were doing the Canadian Academy of Health Sciences report, between March of 2022 and March of 2023, when our report came out, well, really April, there were 10 reports on health workforce. Ours was unique in the sense that we were focused on solutions, and we said, we're going to focus on 5 things. We've got a whole bunch of other recommendations, but these are the 5 high impact. Supporting the development and successful and fulfilled Indigenous healthcare learners and practitioners, supporting community engagement as a foundation for rural and remote recruitment and retention strategies, creating safe, healthy, just, and equitable workplaces that have diverse, representative workforces, transforming care through optimized scopes of practice within team-based models, and embedding a culture of health workforce planning supported by enhanced data and decision-making. Guess which chapter I worked on? The one at the bottom. Because that was really important for me. So this was in part based on a review that we had undertaken during the pandemic of how do we increase the capacity in the health workforce. You can increase numbers within the existing cadres of worker, and we did that during the pandemic. We fast-tracked, we brought some retirees back, we fast-tracked students, we increased numbers. We increased flexibility with deployment across health workers, and we increased support for those workers to increase their availability. You know, we had people bringing mobile homes to hospitals so that they health workers were not potentially bringing COVID home. We had, free psychotherapy for health workers by psychologists. We had babysitting services undertaken by medical and nursing students. So this diagram is very similar to the work that we've done and are concluding at the end of the month with Team Primary Care, Training for Transformation. It's really based on the principle that if people are supposed to work together and if we need an all-hands-on-deck approach, shouldn't they train together? Shouldn't they know about what each other does? And long story short, my biggest aha moment from being part of Team Primary Care, not being a clinical educator, is how remarkably little all of the health practitioners know about what each other does. It was just remarkable. So these are some of the things that we did. We enhanced readiness of over 20 practitioners to come and be a part of primary care. We increased supports around interprofessional, equity, diversity, inclusion, accessibility, truth and reconciliation, psychological health and safety. These were the principles that we embedded. And we had targeted initiatives for Indigenous and internationally educated practitioners. We've had partnerships to bring in internationally educated health practitioners on as clinical associates. We have an accreditation program developed by the Indigenous Primary Healthcare Council for learners. Just really remarkable work. And it was really about bringing folks together to enhance the capacity of interprofessional comprehensive primary care. Practitioners working in teams through training, which was the primary issue, retaining through support, and planning tools. So I'm going to walk through a few of these. So as the Canadian Health Workforce Network, we co-led the Interprofessional Collaborative Table. And I want you to just take a look at who we had around the table for a moment. These are often not people that we think of as primary care providers, but they all wanted to be a part of the solution to the crisis that we have in access to primary care, which is part of our broader health workforce crisis. So we had folks share what it is that they do, what their competencies are, and how they could enhance their training to work in teams in primary care, with the adage learning about, from, and with. But the most important there, the foundational, was learning about what each other does, so that when you are out working and you're trying to meet your population needs, who else is it that you can bring to the table? Through the IP Collaborative Table, we're developing a compendium of roles, and it builds on this very large and very heavy textbook. And if you didn't see it, it's at the front, and there are this is online and accessible, all of the chapters, so you can access all of them. So we have 20 plus chapters on the different health occupations, from their history to their regulation, scopes of practice, training, and how many of them there are. And we built on documents, including from here in Manitoba, what your primary care interprofessional team looks like, and guidance from the Association of Family Health Teams of Ontario. And so this is coming soon. Wait for that. And we've also developed a psychological health and safety toolkit. So these are a bunch of curated resources. And I'm also mindful that today is when the Chief Nursing Officer of Canada has released the retention toolkit for nurses, very complementary to our psychological health and safety toolkit. Important to note that psychological health and safety is not about, mental health and kumbaya. It's really about what are the organizational supports for psychological health and safety, being able to leaning into those uncomfortable conversations. So this is a bit of a link to that. These are the 7 themes that are relevant to healthcare that are highlighted in the toolkit. And these are some of the ways that you can go in and search by theme, by format. You are getting privileged linkage to that because this has only been available to participants in Team Primary Care, but we are launching it this month for all of you to be able to use and participate in that. And then on the theme of planning, the Canadian Health Workforce Network has co-developed an integrated planning toolkit in partnership with local service delivery planners. So this is work that we started in 2017 to develop a toolkit, and then we operationalized it both prior to and awkwardly during the pandemic. And the Team Primary Care funds have enabled us to really engage with the Ontario Health teams to go through a series of steps for planning. And these are just a few of the quotes from folks about how important this has been to them. And this is really heartening for us to hear, because we're just kind of pointy-headed data folks, but to hear folks in the community using those data to make a difference for meeting the needs of their population. We've now got a plan of how we can float primary care and get more capacity. Thank you so much for this toolkit. It's certainly raised our capability to do planning in primary care. This work is not just useful, it's vital to the work that we do in keeping the system alive. Their words. This approach is 100% transferable to any place. We've presented in the UK and the US, and most interested in Canada. These and other amazing projects were showcased at just 2 weeks ago, and all of the videos are posted online, and if you'd like to listen to them in French, there is also French. And so please do go to the Team Primary Care website for that. And we concluded our summit with this call to action, or what we call our collective duty to act, that we urge all levels of governments to ensure that investments used for primary care teams includes the required policy, training, and infrastructure reforms, guided by, ideally, interprofessional table convened to support access. And then in return, we said we are going to continue this work. This is a little QR code, but I'll have them all at the end for you. And here is how we've tried to implement our acceleration agenda to mobilize the knowledge and lessons learned from Team Primary Care, building coalition to advance team-based primary care education and practice, focus team-based primary care training and practice with the populations most at need and most experiencing health inequities, and then to advocate for supportive infrastructure and policies for team-based primary care to thrive. All right, so we're moving now to our Triple E cycle, embedding, planning, enhancing data, enabling access to forecast, our Triple E approach. And the reason why you should be planning, in case you don't know, or not convinced as of yet, whoops, there we go. It's really to smooth out the cycles from surplus to shortage. We are always not going to have a straight line. I always found it really funny when they were modeling capacity in the system with COVID, right? We were supposed to plank the line, and that line was straighter than anything. And I'm going, you understand that that line is the health workforce, and they could go up, but they could also go down. There was movement there. This is how the health workforce capacity moves. So we need to smooth these cycles so that we don't have challenges in under and unemployed, and which we probably won't see for a while, but we have seen it, but mostly in terms of access. So in a report that I was invited to prepare for the Deputy Minister at Health Canada, A Path to Improved Health Workforce Planning, Policy and Management, we talked about 3 strategic investments. One was to build and embed standardized health workforce data, purpose-built for modeling and planning, from which you could build timely and accessible interactive decision support tools and build and embed capacity, not just in academia, but in communities, building capacity in the decision makers. And that was what we called our Stronger Data Foundation for Better Decision Making. So with funding from the CIHR, researchers at the Canadian Health Workforce Network are co-developing a minimum data standard purpose-built for planning with input from many, many partners across many professions, across many organizations that are both regulatory authorities, unions, professional associations, educational institutions, employers, accreditors, and across jurisdictions. This will be an open access minimum data standard, completely open access. We just want you to use it. So we've collated data elements from other provincial, national, and international minimum data standards. We dialogued with the stakeholders from all these different organizations about what their planning needs were, because people don't normally talk about, I need this data element, I need that data element. What are the questions that you have that you don't have answers to right now? And then we need to figure out what those data elements. And then we reverse engineered the work that we did in Toronto based on 7 years of planning about what is it that we absolutely need to plan. I'm happy to share that with you. That's a whole other slide deck. This is my case. Without a health workforce minimum data standard, the data will continue to be siloed by occupation and province with limited common data elements, only available at aggregate level for many professions. Aggregate level meaning we've got gender as a binary, age, and province. 3 data elements does not make a data set that you can do health workforce planning with. It's exclusive of certain health professions. If you're not regulated, you probably are not going to be captured. And that's not just personal care providers. That's also a whole range of mental health and substance use health providers. It has been inclusive of little, if any, diversity data. The data pathways are time and resource intensive, so that by the time we get access to the data to do a research project and we want to publish from it, the journals all say the data are too old. So how do you sustain a health workforce research community? And data access, not just for research, but decision making, will be restricted by costs, legal hurdles, and usability. So a little bit more about the integrated primary care workforce planning toolkit. We are able to do this toolkit because Ontario has invested in a minimum data standard. It's not the best, but it's something. And so we are able to work through these different steps. We are able to create dashboards for each of the steps. To understand community characteristics, to understand service requirements, to understand health workforce capacity. So let's talk about that one a little bit. This is our step 3. We are able to identify service capacity. We have better data for physicians, but I want you to see this box. Because we have data across different interprofessional practitioners, called here allied health practitioners, but that will be changed. We are able to see in a community who else is available that could be brought in to shore up the community. And our partners in Toronto are creating new hubs to address unattached patients by bringing in and recruiting all of these other practitioners through the Ontario health teams. So this is very, very important. This is made possible because of investments in health workforce data. And then we have others, step 4, which is assessing alignment, right? What are our projections, our needs versus capacity, because you don't want to see an X, because then you have to do something like, okay, what are the different scenarios that we can do to help improve that situation? So we have population growth, mobility. We will have a long COVID model there. We will have a burnout model there. And then we put it all together so that people can see that. Interactive dashboard. This is a Tableau dashboard, but it's being put on a Power BI. I don't know what is used here in Manitoba, but they use Tableau in Alberta, which is where we started some of this work. And then we're building capacity through our bilingual health workforce studies micro program. So minimum data standards, decision support tools, building capacity. And so there are 2 courses, Introduction to Health Occupations in Canada, which follows the textbook, and Introduction to Health Workforce Planning, Policy, and Management, which I'm very happy to present a couple of modules in the workshop tomorrow. We received funds from the Ontario Ministry of Education to develop micro-credentials. They're really pushing for that. And we've most recently partnered with the Canadian College of Health Leaders that doing these 2 courses, doing this micro program, will constitute a health workforce leadership specialty as part of your CHE. Now, also in 2021, the Canadian Health Workforce Network led a call to action for better planning, better care, and better work through better data. And we got over 70 organizations to sign on to this. Organizations that don't typically get along well with each other or agree, and they all agreed. And 30 individual and health leaders. And so we were really pleased that they've all signed on to this. And it was based on the argument that given that the health workforce accounts for more than 10% of employed Canadians, over 2/3 of healthcare spending, which really was $175 billion in 2019, or nearly 8% of Canada's GDP. We said, shouldn't support for integrated health workforce planning, policy, and management be key priorities for different stakeholders? We were ecstatic when this was announced in February through the Working Together to Improve Health Care for Canadians that they were going to fund a Centre for Excellence on the future of the health workforce, and this has become, as of December 6th, Health Workforce Canada. So it is like a new pan-Canadian health organization, which will be working closely in partnership with the Canadian Institute of Health Information. They are still developing what their plans are. I hope all of you will be involved in shaping what those plans are. They have a survey out right now, you may want to. So what they will undertake is in development, but the following are what we have pulled together from leading international practices. There are many countries that have a Health Workforce Canada type of organization. First is to collect, synthesize, and share standardized data, developing early warning systems, of which we have none, curate evidence and share strategies, conduct applied research and policy evaluation and analysis, develop partnerships to mobilize stakeholders around policy coordination, and to build capacity and facilitate networking. And this could be an evidence-informed starting point. So just to conclude, what's needed to address our health workforce crisis? Investment in evidence-informed RRR and EEE initiatives supporting spread and scale of leading practices, primarily retaining our health workforce and planning to support them. Investments in health workforce data, including accessible decision support tools. Planning should not be done in a black hot box behind closed doors. It's best done out in public. And 3, investments in building analytic and research capacity. And across all of these, gender needs to be explicitly considered. So please join and connect with us. These are all of our various socials. And as I promised, in case you missed the QR codes, the first one is for our Psychological Health and Safety Toolkit. The middle one is our call to action. And then if you want to get access to our textbook, that's the last one. So thank you so much.
So thank you very much, Dr. Bourgeault, for this very engaging presentation. We do have some time for questions. So there are 2 microphones that are on either side. So we have about 15 minutes. So please come on up. And thank you very much again. Thanks.
Hi. This feels weird, but anyways, I'm Stephanie. I'm a PhD student in the College of Nursing. I'm also a leader in the health system at the WRHA. I'm director for the Indigenous Health Program Patient Service Team. So I really did appreciate your presentation, and I'm just wondering, when we're looking at gender-based analysis, I'm assuming a lot of that's rooted in critical theory and really looking at how power is distributed and voices or privileges and or silence within the health system, and that's something that my nursing colleagues and I will spend a lot of time with, and I think maybe we can talk about, how that affects the nursing profession and women as health leaders explicitly. But I guess the other question that I have is, are we ever really looking at turning the lens from the health workforce and then looking at a system that continues to privilege capitalism and capitalist standards of efficiency over caring, for example, and how that might create ethical dilemmas within health service providers that's leading to, increased attrition? And I'm wondering if you could speak a bit to that, please. Pardon me, I get nervous on the mic. Yeah.
Thank you so much. That was such an important question and set of comments, and it very much speaks to, my training as a sociologist to, critique the systems that we're in. And I think that we need a substantial rethink. I think the crisis is causing us to do that substantial rethink, absolutely, because some see opportunity in this crisis, opportunity to make a lot of money. I was contacted by folks in the media talking about how some of the agencies are trading on the TSX. So it's very much embedded in that system of capital. So it's I've talked about it as an insidious form of privatization, because a lot of the media reports focus on why are nurses doing this, and instead of focusing on, not the nurses don't get all of the money, and it goes to agencies, and could we shine the light on that? And so there seems to be both this commodification of care and a devaluing of care. And that's a very interesting conundrum. I mean, it's interesting, for me sociologically to look at that, but it has very important implications practically for those who are doing that work. And so I think that we need to lean into those really uncomfortable conversations to critique what is happening, because there has been an inappropriate application of certain management approaches to dealing with care work that is very distinct from the industries from where those policies and approaches have been derived from. And so I think that we absolutely need to derive those management policies from within and ask people, some of the elements that we have in our toolkit are stay interviews, asking people what makes them stay or what would make them stay, right? Because we all have heard of the exit interviews, which I don't find particularly useful. Whenever I've left a place, I've never been honest about that. And I think that you should invest your energy in retaining people, not necessarily on sort of chasing them after they've decided to leave. I don't know if that answers all your questions, but you've opened up a very interesting space to explore. And I think that we need to have a really crucial conversation in that regard. Thank you.
Hello. I'm Jess. I'm going to build a little bit off of what Stephanie was saying about power. Firstly, I really love the approach that you presented, very upstream approach to addressing some of these issues. A lot during the beginning of your presentation, you talked about the impact of socialized gender roles and stereotypes, which are, I'll point out, values brought over by white European settlers. And Foucault would say, this is also about power regulation and control of the workforce for capitalism. So from an even more upstream approach, what role do you think disrupting, queering, and decolonizing gender roles has in health workforce planning? And has that been part of the discussion to sort of start even from birth and then health education and then health workforce planning? Thanks.
Well, I think with everything, we need to affect change of those in the workforce, those coming into the workforce, those considering coming into the workforce, and even sooner, right? So you have to have sort of a multiple focused strategy in that regard. It's very difficult to have any non-binary approach to health workforce planning when your only data are male-female or, men-women. It's the reason why we have in our minimum data standard, we've included sort of the latest guidance in regards to how to ask around non-binary and how to do that and when to do that. So we're developing some guidance as to when you would want to include that, in the same way that we have an Indigenous team that is developing guidance around Indigenous data sovereignty for Indigenous identity data that should be collected, but by whom and who would steward those data, and a similar conversation in regards to ethnicity. You wouldn't collect that data upon initial registration, for example, if you were looking at regulatory authorities, because you don't want it to be seen that these are elements that are going into the decision as to whether or not to register someone. So the guidance is looking at collecting that data upon renewal. Or perhaps those questions would not be asked by regulatory authorities, but they would be asked by unions, professional associations, but at least you'd be asking the data using a common identifier so you can integrate the data. So trying to really be mindful of that. So we need to, in order to kind of decolonize, de-binary, these spaces and our conversations, we have to have the data to do that. And you have to do that in a way that's mindful, so working with communities to put a set of cautions around how those data are collected, who stewards them, and then how they get used. But we have to get started, right? Yeah. Thank you for the question.
Fascinating discussion, and I appreciate the first two questions. I was wondering about the transparent decision-making in healthcare and how that intersects with essentially what are political decisions that can vary, government to government, because, the way systems optimize on outcomes, care quality or cost, are often almost political, and if you look at the pandemic and recent changes in health and what is evidence and truth and misinformation, how do we have transparent decision making if there's no shared definitions potentially across political spectrums in what is a fact or what is evidence, and how does that influence the research that you do?
You ask a fundamentally important question. Thank you. And we didn't plant that one. When they talk about, nobody wants to talk about health policy during an election because it's the third rail of politics, right? The reason why it's the third rail is because of health workforce policy, right? The groups that politicians are afraid of are organized health professional organizations. That's what makes health so political. So we're dealing with the third rail of the third rail with health workforce policy. I truly believe that we can depoliticize it. And we depoliticize it by bringing decision-making tools as close to service delivery as possible. I don't think the federal government should be doing health workforce planning. Absolutely not. Well, they could do health workforce planning for the services that they deliver, right? They do operate the 5th or 6th largest healthcare system, so they could do that. However, this is the learning that we've had working in Toronto. We bring the tools closest to service delivery. We provide them with some really grounded data of what their community is, and it's a back and forth. It's like, is this surprising to you? Well, no, we kind of knew what was happening in that community. We do it by neighborhoods, we do it by geography. It's all, the planning is in the spirit that primary care should be available to all Canadians in the same way that primary school is available to your kids in your neighborhood. So it's based on that kind of principle. You bring it closest to service delivery as possible, you do it, you engage the stakeholders, and then it isn't this black box phenomenon that's done in the back rooms of the province or the federal government or wherever by a national union or national professional association. It's very 20th century to do workforce planning by physicians, by nurses, as if physicians don't work with nurses and nurses don't work with other people. My understanding of how health workers work is they work in a sector, they work in a community, and that's where planning should be integrated, closest to service delivery as possible, and you depoliticize it. And the last conversation that we had with the folks in Toronto is that they said, we don't have any policy levers to increase the educational programs. We go, no. But when you, and one of the communities did this, was beautiful to see, when you use the data and project forward, they say, in our community, we need 20 more primary care physicians, we need at least 30 nurse practitioners, and we need 300 other primary care providers. So they have numbers, and then they go to their local colleges and universities to say, this is what we need just in this community. When they did that, the other communities said, so how did you do that? We need to do that as well, so that they can come together and together put pressure on their local education programs to ramp up in a way that is projecting out. And we also do projections. Again, it's not wise to do projections beyond like 10, 20 years. It's as if you're setting sail with the Titanic and you were never going to steer it past an iceberg, and you know what happened there. you need to be projecting out 2, 3, 5 years, and you need to course correct. You need to, what our colleagues in North Carolina are doing is they're forecasting, and then they backcast what they forecasted. Because they've been doing this for 20 years, they can do backcasts. So, you know, we've said the best time to have started health workforce planning was 20 years ago, but the next best time is now. So let's get started so that we can have some data to backcast in order for us to kind of like, are we moving in the right direction? I hope that has answered your question.
Thank you very much for your presentation. I think I probably actually need to just review the slide where you talked about the 5 solutions. And I don't know if that's easy, but there was one related to community engagement. And I was just wondering if you could just share a little bit more about what that means or what that looks like, or just to say a little bit more about that.
Absolutely. So there are different levels of community engagement. You need, so specifically to that slide, so these were the 5 priority pathways from the Canadian Academy of Health Sciences report. It's online, free, you can have a look at that. So that was released in April 2023. What we were speaking about there was we need to build capacity in rural and remote communities to sustain the workers, because it's not just plop a worker into a community. There needs to be community support. They need to be integrated. And you know, coming from a rural community, most of my family lives in a rural community, that's very salient to me, about, you know, what you need to do. And this is a challenging issue worldwide. Like, every country has a challenge with sustaining their rural workforce. You know, best practices are engaging the community, for the community to sponsor students to go into particular programs. And if we had tools in the communities like we have in Toronto for the communities to say, I think we need, here's what our population needs. We need this provider, and this provider. Okay, we're going to sponsor those students to take that training. And many of the training programs, you know, I think about, you know, the Ontario Midwifery Program, for example, most of their training happened in community. So they recruited locally, they trained locally. They were using distance education way before the Northern Ontario School of Medicine, like way before the pandemic. And they were attached to that community to go back. So these are some of the ways to engage in the community, you know, to plan for, to support workers, to sponsor student loan programs, to sponsor tuition, you know, forgiveness, to housing, all of those sorts of things. Like, housing came up as such a huge issue in recruiting rurally. Like, one of the folks that was talking to us, you know, they had really good jobs, you know, for example, up in Yellowknife, but they had no place for anybody to stay. So people were sort of flying in, doing a shift, and flying out. That's not a way to sustain a health workforce. So I'm hoping that helps in terms of, you know, community engagement. The more that people do this, build capacity for this, they feel engaged, and then they feel that the health system is not something that others do and that it's political. It brings it back, you know, to that support. So that's my hope. I think it's quite consistent with some of the approaches we've been using.
So thank you again. On behalf of the College of Nursing, just present you with this. But if everybody could just join me again in a round of applause for Dr. Bourgeault. Thank you so much. This is wonderful. Good. So, sorry. No. Thank you, everyone, for joining us this evening. Hopefully you all had a wonderful, wonderful time, and I can't thank you enough for this very engaging presentation. I think it's something that we've hopefully been able to really think about and then engage with our colleagues in more discussion around this very important issue. So have a wonderful evening, everyone. This concludes our event, and hopefully everybody has a nice, safe drive home, and it's not too slippery out. I haven't checked lately. We do still have some refreshments, so please do, it's not a rush, you don't have to leave. Please do have some of the refreshments, and again, thank you for attending this evening.